সাথে খালি করে যাচ্ছে ওয়াটার সাথে কিছুতে পারেনি।
So good afternoon, everybody. Welcome to this afternoon episode of Pursue. And today we have Pursue 5.0, and this is General Pathology and Immunology. And today's topic is the continuation of last week's topic of immunity and hypersensitivity. In the last week, we had discussed of hypersensitivity reaction 1 and 2. And from today, it will be a continuation of that. And to talk on that, we have again with us Dr. Major Palash Mandal, who is an associate professor in pathology in Sagore, Dutta Medical College, Kolkata. He is also the lab director of Desun Hospital and Heart Institute, Kolkata. Before I ask him to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Palash Mandal, sir. Sir, please share your screen and start. Thank you so much.
Thank you, sir.
Yeah, I can see your screen, sir. Yeah, make it full screen, please.
All right, sir. Good afternoon, everybody. So we will be continuing our discussion on hypersensitivity, which is a part of immune reactions. Actually, they are adverse immune reactions, to be very precise. So we will continue with our topic. So we had already told you that there are 4 types of major hypersensitivity reactions. Actually, all the hypersensitivity reactions have been grouped into 4 different classes. Okay. So we have discussed the class 1, class 2 or type 1, type 2. Now the rest, that is types 3 and 4 will be discussed today. Okay. This takes some time in my laptop. I have seen previously also, just bear with me.
No issues, sir. It'll get settled.
Right. So type 3 hypersensitivity reactions. It is also known as immune complex mediated disease. Okay. So if you remember, type 2 was also immune related disease, but what happened was that the antibody there attacked the antigen which was present in the tissues. I hope you remember, because everything is linked. You see, here what happens is that here also all these reactions are immune mediated. Okay, so don't get any other ideas. So the basic thing is that they are all antigen antibody reactions, all of them. Okay, but now the mode of action is different. The reaction, the inflammatory cells which are liberated are different, and they occur in different diseases. Okay, so as we are ultimately going to discuss medicine and treatment, so everything will be related to the disease as such. Okay, whatever examples we will give, that will be of a disease, human disease, and based on that actually the treatment protocol is formulated. Understand? So here what we are discussing is that immune complex mediated disease, what happens is that the immune antigen antibody complex is first formed. In the second type, we saw that was also immune mediated disease, but the antibodies were attacking the antigens present on the tissues. For example, the antigen was present on the RBC surface, and the antibody which was produced against the self antigen of the RBC surface led to the formation of hemolytic anemia, because the antigen was there in the RBC, on the surface of the RBC. The antibody attacked the antigen on the RBC, and eventually that led to the lysis of the RBCs and eventually phagocytosis by the macrophages. Here what is happening? A bit different. The antigen antibody complex is first formed in the circulation itself. Okay, so antigen is there, some circulating antigen is there. Antigen may be of the same, from our own body's antigen, or a foreign antigen, microbial antigen or any other antigen which is foreign to our body. Okay, so now the antibody which is produced from the plasma cells, they go and attack the antigen and form a antigen antibody complex. This is the first phase. Okay, so there are three phases of this type 3. So first phase is formation of the antigen antibody complex. Am I clear? Next phase, what happens? This antigen antibody complex, which is also known as the immune complex, it gets deposited in some place. Where is the place? It is the blood vessel. It is the inner wall or the intima of the blood vessel. Which blood vessel? The narrow blood vessels, not the arteries, not the thick ones, the bigger ones, the very narrow arteries. Where are the narrow blood vessels? Suppose glomerulus, the kidneys, the brain. So the vessels which are very, very narrow, the capillaries which are very, very thin, so in those places the complex gets deposited. The reason being, because the complex are not able to pass. That is one reason, and they have a preference towards the capillaries and thinner areas where they can get deposited and settle down comfortably. Okay, so this is this particular complex. When it lands at a particular area and settles down, it does not sit quietly. Had it sat quietly, still some problem would have been there, but not major problem. But what it does, it starts its secondary activities. It starts some series of reaction leading to complement activation, and ultimately there is, through Fc receptors, the WBCs are activated, the neutrophils are activated. Okay, so by WBC activation means the neutrophils, these complements, they lead to the liberation of cytokines, which will lead to the attraction of neutrophils, and the neutrophils will come to that area of where the complex is there and lead to an inflammatory reaction. Okay, eventually the reaction is an inflammatory reaction, but the way is a bit different. Okay, so that was the second phase. Now the inflammation becomes more and more intense. Okay, and eventually the inflammation leads to tissue injury. The tissue becomes necrosed. Okay, so had there been only mild inflammation, still problem would not have been so bad, but this leads to tissue injury, and that particular tissue injury is called acute necrotizing vasculitis. Acute necrotizing vasculitis. So dense neutrophilic infiltration occur, and they lead to the destruction of the wall of the vessels. Thin walled vessels are there, the capillaries are there, the blood vessels become destroyed and eventually they are ruptured. Okay, so that thing is leading to all the calamities. The classic example being SLE, systemic lupus erythematosus, where the nuclear antigens are there. The nuclear antigens, they are the self antigens, mind you, body's own antigens. The body's own cells nucleus are there, which are being attacked by the antibodies. So all these are autoimmune diseases. Okay, so SL is an autoimmune disease and leads to host of problems in our body, starting from the kidneys, leading to nephritis, vasculitis, the skin lesions, arthritis, the bone lesions. It will not spare anything. The SL is a very bad disease. Okay, so that was SLE. Then comes post-streptococcal glomerulonephritis. This particular entity is a disease of streptococcus. The The streptococcus, whenever it attacks us, suppose some streptococcus pharyngitis has happened, or streptococcus skin lesions, the impetigo, those have happened. Okay. Now, whenever the post-streptococcal pharyngitis happens, preferentially those antibodies which are produced against the streptococcus pharyngeal bacteria, those particular bacteria, they have a preference towards the heart tissues. Okay, so the endocardium, the myocardium, the pericardium, so they get deposited in the heart. The antibodies, they get deposited in the heart. Okay, so that is rheumatic fever that we saw in type 2. Okay, the antigen was there, the antibody attacked. Here what is happening, the post-streptococcal glomerulonephritis, here the complex is forming first in the blood vessel, and that is the that's the flowing blood. The antibody complex was formed, immune complex was formed, and that immune complex went and got deposited in the kidney, leading to glomerulonephritis. So post-streptococcal glomerulonephritis, which is happening due to impetigo, is leading to this kidney disease. Okay. Now there is another disease called serum sickness, where some foreign serum protein like horse serum, which was used for the treatment of this tetanus long time back. So those foreign serum proteins led to the formation of immune complex in the flowing blood, and that immune complex got deposited in various places like the bones, the joints, the kidney, and any other places of the blood vessel, leading to this arthritis, vasculitis, and nephritis. Okay. This is the pictorial representation taken from Robbins. The same thing which I told you, the phase 1, where the antigen was there, and the antigen was came on the B cell after being presented by a APC, that is antigen presenting cell, which is not given here. So this B cell got transformed into a plasma cell because that is called class switch. Plasma cell transformation is must, otherwise no antibodies will be produced. B cell itself cannot produce antibodies unless it is transformed into a plasma cell, which is a modified B cell. Okay, so B lymphocyte, once it gets transformed into plasma cell through specific signaling and class switch, it starts producing some specific antibodies which are directed towards that antigen, leading to the formation of antigen antibody complex, also known as immune complex. Okay, so first was the formation of the coming of this antigen, and second was the formation of the immune complex. Okay, this immune complex formation led to this neutrophilic attraction. So they had these FC receptors, and they have this complement receptors, that is C3b receptors, which attracted the neutrophils, and the neutrophils got hooked onto this antigen antibody complex. The complex had already been deposited in the blood vessel wall. You see, this is the lumen of the blood vessel. This is the cross section of the lumen of the blood vessel, and this was being formed within the flowing blood, and this complex which was formed, it lodged in a particular capillary, and here it started attracting the neutrophils. This is a neutrophil, and this is the antigen antibody complex, also known as immune complex. Okay, so there is the inflammatory reaction, complement deposition, and eventually this inflammation led to the release of granules from the neutrophils. You see, the neutrophils have a lot of granules, the proteolytic granules, the lipolytic granules. So all these granules were released after the neutrophil got activated and led to this intense reaction that is known as vasculitis, and these lysosomal enzymes, they lyse the wall of the blood vessel, and neutrophils, lot of neutrophils are there in the blood vessel, and leading to the lysis and necrosis of the blood vessel, which is known as leukocytoclastic vasculitis. Leukocytoclastic vasculitis. So this is a pictorial representation from Robbins. This is an actual micro photograph of the same thing. Micro photograph means the section has been taken from the lesion, the H&E stain has been done, and you are seeing under the microscope. This is a high power image, and the picture which has been taken through that objective, this is the picture. So this is the blood vessel wall. Can you identify anything? It all looks red, 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 red. So this is a necrotic area. So this is necrotizing vasculitis, and all these cells, if I could show on the high power, that all these cells are neutrophils. So everywhere these are the neutrophils. So these are the neutrophils. This is a particular capillary. The wall of the capillary has been destroyed by these neutrophils, of the enzymes of the neutrophils, leading to vasculitis, and everywhere you see fibrinoid necrosis. This is an example of a fibrinoid necrosis which is surrounded and infiltrated by neutrophils. In the lumen also a lot of neutrophils are there. In surrounding area also a lot of neutrophils are there, and this is the exudate which is coming out, and there is a reddish appearance of the whole thing, that is, which is a fibrinoid appearance. Looks like a fibrin, but actually it is a necrotic area. Okay, so this is a picture which is again taken from a glomerulus of a kidney. This is called immunofluorescence image. So there is a immunofluorescence microscope. Some immunofluorescent reagents have been used, and this particular thing shows the deposition of IgG in the immune complex. So this IgG, that is the IgG complex, and got deposited in the glomerular capillaries, and the fluorescence has been shown, and this is taken up by a fluorescent microscope. This micrograph has been taken, and this is visualized, again taken from Robbins. All three pictures are from Robbins. You can go back, look into your book, and have a better idea if you want to. Okay, so these are the examples of immune complex mediated disease. Why are these given? Because they ask you in the viva, give some example of immune complex or type 3 type of hypersensitivity reaction. So you will say lupus, that is SLE, systemic lupus erythematosus, where the antigens are the nuclear antigens leading to all these reactions. There is a post-streptococcal glomerulonephritis, polyarthritis nodosa, reactive arthritis, and so on. I have already told you the names. So these are the names, these are the antibodies, and these are the clinical manifestations. Okay, so at least remember 3 names. If you remember 3 names in the viva, it will be okay. You can write it also in your theory paper, but try to draw some diagrams. This is my request to you. Why I have shown you these things. This previous it is okay. This type of writing is fine, but if you draw diagrams, that will give an added impression to the examiner. That will give a added value to your answer. Okay, so always practice the habit of drawing diagrams. This is hand drawn diagram. Okay, representation is good, but you have to practice drawing these diagrams yourselves. So this diagram also can be drawn, no harm. This is a little difficult to draw because it is an immunofluorescence image, but at least you can draw this diagram, you can draw this diagram. Better to draw at least this phase wise diagram. This is a better representation, and in the theory exam, whenever you are asked to write a short note, please draw diagrams. Okay, that is my request to all the, especially the undergraduate students. Even the postgraduate students, if they get an exam question like this, they can also draw diagrams. Definitely they should. Now coming to the type 4 hypersensitivity reaction, delayed type of hypersensitivity reaction, more important because it is related to a very important disease, that is tuberculosis. Okay, so tubercular reaction, whenever we do testing for tuberculosis through Mantoux test, so that skin reaction or the tuberculin test, same thing. So that reaction is elicited by this delayed hypersensitivity reaction on our skin. Okay, so please remember this because this is very important. Because not only tuberculin reaction, contact dermatitis, rheumatoid arthritis, all these are by the same type 4 hypersensitivity reaction. Okay, now you have to understand how it happens. So in immune complex, the main cell was the B cell. B cell was producing antibodies. Even in type 2 and type 3, the antibodies were the prime attacking mode. That is, suppose if you think of fighting, so those were the bullets or the guns. Okay, so the antibodies were the main fighting instrument. That is the you can call them guns or you can call them bullets or whatever it is that was there. But now this is different. Here what is there? So the T cells have come into picture, and their mode of action is through liberation of some cytokines. So here the guns are different. Okay, so here the guns are different. Why I keep on giving example of the bullets and guns? Because I myself was in the army. So anyway, so what is happening is there is an antigen which has come into our body. Okay, so as I told you, like always, this antigen will be presented by the antigen presenting cell, which may be a dendritic cell, which may be a macrophage, and it will come towards the naive T cell, that is CD4 type of naive. Why is this the word naive? Naive means innocent. Innocent means their cell has never been exposed to some antigen. Okay. Had it been previously exposed to an antigen, it would not have been naive. Okay. So, naive means immature. Naive means a person who does not know anything. Then it is that word can be used in different ways. Okay. So, that is a naive CD4 T cell. Now, what happens is that the interleukin 2 leads to this particular transformation from a naive T cell, that is CD4 cell, into Th1 cell and Th17 cell. These 1 and 17 are again part of subset of CD4 cells. So you can say that this one is also a CD4 cell, this one is also a CD4 cell, but by virtue of certain other actions, they are subcategorized or subdivided. So this one becomes a Th1 cell of CD4 lymphocyte, and this is a Th17 type of CD4 lymphocyte. Am I clear? So why Th1 and Th17? Because there are some additional cytokines like interleukin 12 and interferon gamma, which lead to the transformation of naive CD4 cell into a Th1 cell. Now, if these cytokines are replaced by these cytokines, interleukin 1, interleukin 6, interleukin 23, and TGF beta, so now this same thing may be transformed into Th17 cell. Okay. Now, whenever this subset is formed, there again it has got two ways. One is that a memory pool is formed. Okay. So now memory pool means, so this cell is not alone. Okay, we may be seeing a picture of a single cell, but actually a multiple number of cells are produced, a multiple subset of cells are produced. Okay, so pictorially they are showing only one cell, but actually in reality or in our body in vivo, a number of cells are produced at the same time. Fine. Now this number of cells, some of the cells go to the memory pool. Means as long as those cells are alive, they will remember that this antigen came to our body. Okay, so they will recognize. Why they need this recognition? So they know that if it comes again, if they see that antigen again, they will know that this is an enemy and they will attack directly. So then the transformation of naive to this is not needed. They already have a knowledge, so they are not naive anymore. They are matured, they are exposed. Okay, so that leads to the transformation of memory pool into immediately attacking pool. Okay, so the memory pool are the people who are in the back bench or in the who are the players who are sitting on the fence or the bench. Okay, So whenever this some player who is playing is having an injury, that player comes as a replacement. So the memory pool acts something like that. Okay. So this is same for both these sets, memory pool. Now the action, what it happens? So whenever there is a second exposure, the first exposure, as you remember in the type 1, the first exposure is not leading to much action. It is only leading to a formation of a memory pool, or that particular agent may be eliminated at that during that action. Okay. Now during second exposure, the reaction becomes intense reaction. So that leads to liberation in case of TH1, liberation of interleukin 12. So please remember these names. Interleukin 12 was acting here also. So now TH1 is also leading to liberating interleukin 12. So these cells themselves are leading to liberating some cytokines, and these cytokines are again helping the naive cell to be converted into a particular subset of cell. It is like a cyclical reaction. Okay. So this itself is leading to more formation of TH1 cell from naive T cell. Understand? So this interleukin 12, after second exposure has happened with the same antigen, leads to liberation of more cytokines. More cytokines. What are the cytokines? Interferon gamma and tumor necrosis factor, TNF and interferon gamma. So now interferon gamma was here also. So you see this, that's why I told you this is the same cyclical reaction, a chain reaction. This is leading to formation of these cytokines. The same cytokines are again leading to formation of say a group of subset of same type of cells. Okay, the chain reaction is going on. Now the cytokines which are liberated, the more important one here is a interferon gamma. What it leads? Interferon gamma, you remember, leads to macrophage activation. So please have these ideas, which one is activating what. At least have macrophage is a very important cell. As I told you, we had a good discussion of chronic inflammatory cells, and macrophage we discussed at length. So macrophage is activated by interferon gamma. By activation, what did I mean? That macrophage, which is resting in the tissue, mainly its action is to phagocytose. Okay, but phagocytosis is not so simple. So it does not go and just eats it up. So there has to be some other associated activities also. So macrophage, before phagocytosis, it has to acquire some power to kill that thing and then eat it up. Okay, so that particular power is given by these cytokines, the principal cytokine being interferon gamma. And macrophage activation can lead to formation of epithelioid cells. Epithelioid cells, as I told you, remember I showed you the diagram of this robo where Rajnikant became multiple. If you remember, if you remember the previous classes, so I had shown some picture where I had taken it from the this cinema robo, which showed the robo where Rajnikant was acting, that got multiplied to fight a enemy. So here also these macrophages, they get transformed into cells and they get fused into cells, and the fused cells are known as the giant cells, the Langhans type of giant cells, where there are rows of nuclei around the cytoplasm in a form of a horseshoe or bipolar. So these are nothing but the activated macrophages. They are nothing but activated macrophages, both epithelioid cells, which we discussed in the granuloma formation, and also the giant cells. These giant cells, not the foreign body giant cells, these immune giant cells, they are nothing but activated macrophages. Okay, am I clear? Why I am going slow? You see, I want to make you understand and link with the previous notes we discussed. Okay, so if you link those ones, that is the chronic inflammation, granuloma formation, you will understand that this delayed type of hypersensitivity reaction here also in Th1 cell activation, the granuloma is the final end product. Granuloma is the end product. Okay. So the classic example being injection of a tuberculin antigen, that is the MAN2 test, MANTOUX. It is pronounced as MAN2, not MANTUX. It is MANTOUX. Okay. So you will read it up in your ComMed, and you will also see in medicine. So this is a MAN2 test, which is a tuberculin test being done to see the immunity or the immunity of an individual against tubercular antigen indirectly towards tubercular protein, that is Mycobacterium tuberculosis. Fine. Now this other group of Th17 cell, what it does, whenever there is a second antigen exposure, this APC is antigen presenting cell, and it leads to the liberation of this interleukin 17 and interleukin 22. Not the same ones. Not IL-1, IL-6, 23. There is a separate subset of cytokines, interleukin 17 and 22, leading to acute inflammation. So there is a difference. This type 2 hypersensitivity reaction through different channels leads to different type of reaction. In the first type, that is through Th cell 1 and 1 activation, there is granuloma formation, and through Th17 cell activation there is inflammation, and where neutrophils and monocytes are predominant cells. Okay. So and in the third category there is CD8 cell activation. Third category, why? Because if you consider it as a 1, it is second category. If you consider it as 2, it is third category. So let us consider this whole thing as a 1. So second category is CD8 cell activation. CD8 cell is again a T cell, but CD8 cell is a cytotoxic T cell. It directly attacks and kills, okay, through some anti cytokine, of course, but the direct capability of a killing by CD8 cell, that is why it is called cytotoxic T lymphocyte. Okay. Now the example of this is type 1 diabetes mellitus. In type 1 diabetes mellitus, the islet cells of the pancreas, they are directly killed by the this CD8 cells. It is again autoimmune disease. Self-antigen, antigen of the islet cells in the pancreas, our own body, being attacked by the CD8 cell, leading to destruction of those islet cells, and that is an example of type 1 diabetes mellitus. Okay. So you see, the same type of disease, that is type 4 hyper delayed reaction, is leading to multiple diseases. Okay. So here this example is better illustrated. This is picture from Robbins, where they are showing the same thing which I discussed. I am not going to discuss it now. Why did I give this example image from the book, so that if you go back to your book, you can look into it, have a better idea. That's it. Examples, as I told you, tuberculin reaction, type 1 diabetes mellitus, rheumatoid arthritis, contact dermatitis, all these are examples of type 4 hypersensitivity reaction, but the modes may be a little different. So we have come to the end of hypersensitivity reactions. So this is in a nutshell which has been given again from the Robbins. So you can go through it. Why? Just going through it, you will have an idea before appearing for the viva, suppose, or just before going to the examination. Just once you go through it, because that time before going to the examination hall, you will not have so much of time reading 1, 2, 3, 4 separately. This is one chart where everything is given together, so to make you understand better. Okay. So here the type 4, again I am telling you, what is happening here? The T cells are there, and here the B cells are there, which are more active. T cells are leading to release of cytokines, inflammation, macrophage activation, and the other group of cell, that is T cell mediated cytotoxicity through it, leading to type 1 diabetes mellitus. And this is the what is happening, the lesions leading to this granuloma formation, edema, cellular destruction, and so on. And in the type 1 we saw most important thing was the production of vasoactive amines, which was the classic example in bronchial asthma, okay, atopy. And the inflammatory cells were the eosinophils. The cells which were releasing amines were the mast cells, okay. Just a recapitulation. Here, type 2, what we have? The production of antibodies like IgG, IgM, and the antibodies were directly attacking the antigen present on the tissues. Unlike the third one, where immune complex was being formed first, which was attacking the tissues. Okay. Attacking will be there because it is a hypersensitivity reaction, it is a destructive reaction, it is a type of negative thing in immunity. Okay. So this is not a thing we want. This is something which has come and which is a harmful effect of immunity. Okay. So whatever it is there. It is one of the most difficult. These are all diseases which are very difficult to treat, and they keep on recurring, and eventually some of the patients may lose their life also. So that is it. We have come to the end of the discussion. If you have any queries, you can write back, and I will be happy to answer you through this forum. Thank you so much.
Thank you, Dr. Palash. Excellent. So we have finished with hypersensitivity, and that's a very important part of immunology, especially in relation to autoimmune disease and renal pathology and so much of multi-systemic disorder, and I think you have dealt with it so nicely. What is going to be our next topic, sir?
Sir, we will be continuing with immunity only. So right. I will discuss exactly the topic, but immunity I will have 2 more classes. One on HIV/AIDS. That right. is we have to discuss HIV/AIDS, which is a very important topic in immunity. Yes. And we will be discussing the formation of immune diseases, autoimmune diseases. So that is important. We will discuss a bit about SLE, a bit about Sjogren syndrome, something to because how autoimmune diseases are happening. So that part is important.
That is very important. Yes. Fine. So we will continue with immunology for the next 2-3 classes. Thank you so much, Dr. Palash. Okay, yes, 2 classes. Right. Thank you so much. God bless you. Take care. Bye bye.
Thank you, sir. Thank you so much.
Thank you. Bye.